Thanks for joining me. It's kind of early. To kind of dovetail with what Dave was saying is that, what we're doing at VIOS, in addition to what he was saying, is we're trying to dispel some of the myths and some of the misinformation that's in social media. And this is what this talk is more or less about today. We're going to be talking about testosterone. Let me just introduce myself for those who don't know me. Dr. Stephen Winiarski. I grew up in Atlanta, went to Woodward Academy, undergrad at Emory, did medical school in Chicago, spent time up there, was in San Francisco for a little bit. I worked for a company that would later be known as One Medical Group. Maybe some of you are familiar with it. I spent some time in DC, but spent most of my clinical career in Atlanta. I'm a fellow of the National Lipid Association. I'm also board certified in obesity medicine. And all of these, everything that I've done in my career really has been focused on prevention of chronic disease, whether it's lipidology. And in lipidology, what we do is try to prevent the development of heart disease. In obesity medicine, basically, we're helping metabolic disease and preventing metabolic disease. And testosterone plays a huge role in that, as we'll see. So, needless to say, social media has taken a great interest, and the general public has taken a great interest in our testosterone levels for some reason, right? Everyone's talking about it. And you can see on these graphs that venture funding has grown, like a hockey stick, basically exponentially over the last several years. And the number of unique domains that are specific to TRT and testosterone has also grown in a similar way. Unfortunately, social media has muddied the water with mixed messaging and misinformation about testosterone, TRT, what the right level of testosterone should be. Does aging decrease testosterone? Maybe, all of us should be on testosterone. And, according to Joe, all that matters is that you have testosterone in your system. It's that simple. And in my experience, it's never that simple. This was an interesting analysis done in the 2024 annual scientific meeting of the Sexual Medicine Society of North America. And it was basically looking at TikTok videos. No surprise, 72% of those videos were created by companies looking to make money on testosterone. 4 out of 5 really didn't, or 4 out of 50 didn't give accurate information of what testosterone could actually do. Nobody talked about the risk of infertility, and only 1 out of the 22 were physicians. But that's not to say that testosterone is not a serious issue, low testosterone. So 10 to 25% of men met clinical criteria for hypogonadism, which is low testosterone levels. Fortunately or unfortunately, we'll jump into this. The vast majority of those men that have low testosterone, it's due to metabolic conditions. And we're going to dive into those details, and I'll explain what I mean by it. Fortunately, the primary hypogonadism, or low testosterone due to dysfunction of the organs that lead to the formation of testosterone, is pretty rare. Before we talk about how we replace it, we should ask, well, why is the testosterone low? So here are a couple of studies. This is interesting. So Harmon, he looked at a huge group of men, and he found that actually, and let me get my little laser here, healthy aging men had a very small drop in testosterone as they age. And we're talking about 80 here. And there's not a huge difference between 30 and 80 in here. And most of the people that had the drop, which was significant, had to do with the accumulation of chronic diseases like diabetes and heart disease and obesity. Some other studies. So Travison found that, surprisingly, healthy men, as they aged, only had a 0.1 to 0.2 decrease in testosterone per year. That's highly different from what you hear. Like everyone that gets old has low testosterone, they need to replace it. But if you stay healthy, it's really not much different than a 30-year-old. So Feldman, in his study, agreed with Hartman that most of the drop in testosterone as we age has to do with chronic disease, accumulation of chronic disease. There have been some controversial studies here. There was one study by Solomon that looked at a group of men, and it found that if you divide the average testosterone values, the group of men in the lower quartile, lowest fourth, which in his study was under 241, actually had a 40% increase in the risk of dying, all-cause mortality. There was another study that looked at the same data on other groups of people. It was NHANES data. So these are people in the United States, about 10,000 men, showed the same thing, that lower testosterone increased mortality. But what they found was that that lower testosterone value, again, had to do with chronic disease. And that's what was actually causing the death, not the absolute value of testosterone. Finally, on the other side, get my laser here, there was a US Biobank study. It was a what we call Mendelian randomization study. So they asked the question, well, what about looking at men who have genetically high testosterone? Do they live longer? And actually they found the opposite. Men with genetically high testosterone tended to live less long than people with more physiologic normal testosterone. And this probably had to do with heart issues and clotting. So a little mixed message there. So to really understand what causes low testosterone, we have to jump into a little bit of physiology. And I'm not expecting you to memorize this. I'm just going to go over briefly and tell you that this is the feedback mechanism that goes into making testosterone and regulating testosterone in our bodies. And this is a finely tuned system that's been evolved over thousands of years to regulate testosterone. And it's a dynamic system. So it responds to the environment. There's sometimes we don't want a lot of testosterone. There's sometimes that we want more testosterone. And this system keeps it regulated. So the brain triggers the pituitary gland to release a hormone that stimulates the testes, specifically the Leydig cells, to produce testosterone. Testosterone gets broken down into estradiol, which is an estrogen, and that feeds back on the brain, telling the brain that there's enough testosterone. So like I was saying, this is a dynamic system. And the analogy I use, the way I like to remember it, is the temperature in my office. So if I'm in my office, I feel warm or cold, I don't immediately think, well, the thermostat's broken, or the HVAC system is broken, or the ducts are blocked. What I think about is the environment. Has someone left the window open? Has my daughter messed with the thermostat, right? Maybe I'm dressed too warmly. I have a coat on. If I take it off, I feel better. What about what I'm doing? Am I moving around, or am I sitting down, or am I sleeping? So all these things go into affecting how I feel about the ambient temperature. And the first thing I don't think about is that something is broken. Is it possible? Sure, that's something, and I'll look into it if I've already investigated the environmental portion of it and found that there's nothing wrong there. Does that make sense? Why is my... Oh, there we go. All right. So what's the biggest environmental component to low testosterone? And that is visceral adiposity. What is that? So there are two kinds of fat in our body. There's subcutaneous fat, so that's the fat that's on our butt and our arms and our legs. And then there's something called visceral fat, or visceral adiposity, and it's located around our organs. And these two kinds of fats are physiologically, microscopically distinct. They're different, and they function differently, and they respond differently to growth. So as visceral adiposity grows, it creates an environment that inhibits the production of testosterone. So it inhibits all these areas, and we don't have to go into the details, but it increases leptin resistance, increases estradiol. We talked about that feedback mechanism, and these inflammatory mediators that make these parts of the system dysfunction. The other thing that visceral adiposity does is it leads to insulin resistance. Well, what is insulin resistance? So insulin is the hormone in our body that tells our cells, our tissues, that there's plenty of energy available, right? There's glucose to take up. When these tissues become insulin resistant, they're not paying attention to this signal. So they think that there's not a lot of energy. And what happens when the brain, the pituitary gland, and the testes think that there's not any fuel available? They go into starvation mode. So they're not thinking, hey, I need to reproduce. They're thinking the opposite. We're not going to reproduce. There's not a lot of food available. So let's cut down the amount of testosterone. And that's exactly what happens. And we see this all the time. So ultimately, testosterone is a metabolic marker. It tells us how healthy our metabolism is. Unfortunately, we can get stuck in a very vicious cycle of low testosterone. So having low testosterone can create the environment that leads us into metabolic dysfunction. So our visceral adiposity will go up, our muscle mass will go down, we feel more fatigued, we're less likely to exercise, we sleep more poorly, and this is important because testosterone is formed at night. If you're not sleeping well, you're not going to form testosterone. And this leads to worsening metabolic dysfunction, which leads to lower testosterone. So you're caught in this cycle. And this is where supplemental testosterone can be helpful in getting men out of this rut. So the combination of testosterone with other strategies to improve our metabolism or get rid of the metabolic dysfunction, like exercise, diet, and other medications, can actually help. You take testosterone, you feel more energetic, you develop more muscles, you start metabolizing glucose better. Now with the advent of GLP-1s, especially Ozempic and Zepbound, testosterone really isn't needed. These medications are so effective at reversing metabolic dysfunction that most men don't need to be on testosterone for the short time. And actually, I was talking to a patient a couple of days ago, a VO patient, who had been on GLP-1s for quite a long time, had lost 50 pounds, and we were checking his testosterone, and he noticed a significant increase in his testosterone. Before he said he was low, and now he was about 200 nanograms per deciliter higher. So it went up 50% just by losing weight. So he took no testosterone at all. So how do we determine the cause? So at VO, we understand the importance of testosterone in men's health. We've gone over all the studies. But determining whether or not there's low testosterone is not just by doing a testosterone level and finding a low number here. We have to do extra testing to find out why it's low. And we can find out, is this primary low testosterone? So, is there a dysfunction, or is the brain not working? Is the pituitary gland not working, or the testes not working, or is it metabolic? And we can look at that. And we don't not only do these lab tests, we also do a DEXA scan. The DEXA scan is what's going to give us physical and imaging of how much visceral adiposity a man has. And this will again, dovetail with what we see. So if we see some insulin resistance and some metabolic dysfunction, does that go along with the imaging? So we want to make sure that both of these agree before we make a decision. I'm not going to spend too much time on this. This is the downside of ignoring the underlying cause and going ahead and taking testosterone. So, lots of information here. Basically, you're risking infertility. Sometimes that matters, sometimes it doesn't. Depends on how old you are. 10% of men that go on testosterone supplementation don't ever get their fertility back after they discontinue. Another thing that's important is that they feel better, right? Who wouldn't feel better if they have testosterone? So it decreases the incentive to improve the underlying conditions. And there are side effects: increased atrial fibrillation, which is a arrhythmia, increased clotting. So it's not to be taken lightly. I like this slide because it talks about the different interventions that one can take and the effect that they have on our testosterone. So obviously on the top is supplemental testosterone. That's going to give you the biggest change because it's dose dependent. You take more testosterone, your testosterone is going to go up. But not far behind is bariatric surgery and GLP agonists. And important to say that this does not take into account the newer GLP agonists like Zepbound. So these numbers are probably closer to the bariatric surgery numbers. Another thing that's important that I mentioned before is sleep optimization. This is something we can all work on. As I mentioned, testosterone is made at night. If we're not sleeping well, we're not going to make testosterone. And you can get a nice bump in testosterone just by sleeping well. Easier said than done, I know that. Couple of vitamins and minerals. If you're deficient in either one of these, you can get a significant increase in testosterone. On the other hand, if you're replete, supplementing with these is not going to give you better testosterone. So if you have enough vitamin D above 20, you're not going to get a bump in testosterone. If you have enough zinc, you're not going to get this bump in testosterone. Two supplements I'm going to mention. One is ashwagandha, which will give you a nice little bump, and fenugreek, which also gives you a little bump, primarily in free testosterone. And interestingly enough, these are not direct effects. So they don't affect that system that we were talking about directly. It's more indirect. Ashwagandha works on the GABA system, which is basically stress reduction, which is interesting. You're reducing stress and you're increasing testosterone. That just goes to prove that this system is very sensitive. So even an increased stress can decrease your testosterone. So some take-home points here: get the right tests, get the right diagnosis, and then get the right treatment. So what starts the whole process? What stimulates the brain, the hypothalamus, to actually start this process? And it's a secular release of GnRH, which is the hormone. So it releases it in bursts, and these bursts are taken up by the pituitary. And then you start the cycle so that you get that feedback cycle.
What starts the brain to start the signal that starts the whole process?
Well, there's a baseline signal, right? It's like the beating of the heart, right? It's like what starts the heart. Well, there's a baseline, and then once you have that baseline, then you have several different things that can stimulate it or decrease it, right? So you can either stimulate the hypothalamus, you can stimulate the pituitary directly, or you can stimulate the testes directly. And some of those, it's interesting how sensitive the system is. I just named a couple of things and simplified it. But insulin itself can stimulate it, right? So if the body senses, hey, there's lots of food around, we have lots of energy, let's start making testosterone while we have that. And as we start fasting, it goes down again. So basically, we're designed, or this system is designed to reproduce. So anything that favors an environment for reproduction is going to increase testosterone. Anything that is not in favor of reproduction is going to decrease testosterone. If you're stressed, right? So you can think if we were being chased by animals or another tribe, now's not the time to reproduce. Now's the time to run. Or if there's a famine, you're not going to reproduce. So we think of it as a health marker. We think of it as a marker of vitality. But in reality, it was just designed for reproduction, right? And then after we reproduced, evolution said, well, we're not going to worry about it anymore.
Any relationship between cancer and has that testosterone?
Yeah, great question. And the question is there any relationship between cancer and testosterone? They did a study on that because they wanted to know whether or not men on supplemental testosterone had a greater risk of prostate cancer. And the answer was no. And indeed, there was another study specifically that looked at men who were treated for prostate cancer with radiation, not surgery, just radiation. So they still had some of the prostate around. And it showed that the majority of men could take supplemental testosterone and their PSA would not go up. So there's an interesting relationship between testosterone and prostate cancer.
Dr. Winiarski, we had a somewhat related question, so I'll interject. The question was, is it true that once you start testosterone treatment, you have to stay on it?
Okay, the question is whether when you start testosterone treatment, do you have to stay on it? And this, again, goes back to why you're taking it. So if you have a primary defect, and this usually happens in the testes. So the testes are a delicate system, and certain things can damage that factory that produces testosterone. So prolonged high glucose, so diabetics that are uncontrolled can damage the system. They can be damaged in other ways. Trauma is one example. So if you have a defect in that primary system, you can't make enough testosterone, then you always have to be on it. So it's like a diabetic with insulin. They can't produce insulin, so they have to stay on the insulin. For those men that have metabolic dysfunction, as soon as the metabolic dysfunction goes away, then most of them can get off. Not all. And that's the danger, is that when you start, you may have to stay on it. But in most cases, if you don't have an underlying cause or if you haven't been metabolically ill for a very long time, then that system, that feedback system will bounce back after you get rid of the metabolic illness.
Yeah, I thought you made a good point that the testosterone treatment can mask the underlying core issue, which is poor metabolic health.
Yep.
And if you have you're artificially increasing your testosterone,
right,
you may not address the core issue, which
exactly
is
right,
underlying metabolic health.
Right. And it's interesting that, testosterone, we were talking about how you have to get good sleep in order to make testosterone. If you have low testosterone, you can get bad sleep. So if you supplement with testosterone, you can actually improve your sleep. If you supplement too much, then it can actually increase your risk for sleep apnea. So it's this delicate balance. Just like everything else, when we're messing with physiology, we're messing with this delicate system of balances, we start to what I call micromanage it. We think, the body doesn't know what it's doing. I'm going to take care of it. I'm going to give it its testosterone. But we start messing with something that's been around for thousands of years. So we have to be very careful. It's just like any other medication. We have to think about the pros and the cons. Jet, you had a question?
Yes. Does regular use of cold plunge or sauna impact testosterone?
Yeah, that's a good question. So does cold plunge or sauna affect testosterone? So both of those are stressors, right? And in a way, they can be very useful because you get this what's called hormesis. So you're exposing the body to a stress and you're asking the body to adapt to that stress. So cold plunge, sauna can improve and specifically sauna can improve your cardiovascular fitness, so that's going to affect it. You can also get a surge of growth hormone, and the growth hormone can stimulate the cycle, right, to start the release of the hormone from the hypothalamus to the pituitary. So it can, but again, we talked about stress. If you're doing it too much, if you're not doing it in the right way, and this is very individual. Some people can tolerate more sauna and cold plunge than others. So if you're doing it all the time and you're constantly stressing the body and you're not adapting, then your testosterone will go down. If you're using it and you're actually adapting, you're giving your body some time to recover, then you're going to get an improvement. There's some nuance in that as well, but it's similar to training. If you're doing any kind of exercise, if you're constantly working out and not giving your body a chance to recover, you're overtraining, and that's going to decrease the testosterone. And that actually happens with endurance athletes, and they can develop something that's called REDS, which basically they're training so much and they're so calorically deficient that the body downregulates that testosterone, and they can be at higher risk for injury and fatigue. Yeah, so the question is, what does good sleep mean? Is it the quantity or the quality of sleep? So for most people, it means 7 to 8 hours of quality sleep. Some people can do, a small portion of people can do less, but it's both that quantity and quality. So you can sleep, and like I usually do, I can sleep 7 or 8 hours, and sometimes my sleep is horrible. I don't have any REM, I don't have any deep sleep, so you have to get both of those. So staying in bed isn't necessarily going to increase your testosterone if you're not getting that quality sleep. So you have to ask yourself, well, how do I increase the quality and maintain the quantity? And that's always a challenge, especially nowadays, because we have all these demands placed on us. I know with myself, it's like, I know I can go to bed at 9:30, but when is my daughter going to come in and wake us up because she needs something, right? What did I do that day that maybe I'm worried about that night and I'm not getting, I'm staying in bed 7, 8 hours, but maybe I'm thinking about things. So it's always a challenge. And in my experience, when I talk to men about sleep, there's not one thing that makes them sleep perfectly. It's always the accumulation of small changes. So you can say, okay, I'm going to take a magnesium supplement. Okay, I'm going to do some breathing exercises before I go to bed. I'm going to do some stretching. I'm going to regulate the temperature in my room. So you add all these little things and you create an environment for favorable sleep. Unfortunately, there's not an easy answer to getting good sleep. And it's frustrating because you can try hard, and what we're used to is you try hard and things work out. And in sleep, it's almost the opposite. Is you try hard and then your sleep stays the same, stays crappy.
So Dr. Winiarski, we had a couple questions about GLPs. Could you just talk about them kind of generally, pros, cons, benefits, side effects?
Sure.
Seems to be the wonder drug.
Yeah, so it is a wonder drug. GLPs, and I'm going to specifically refer to Ozempic, which is semaglutide, and Zepbound, tirzepatide. Tirzepatide is a little bit different because it's GLP and GIP antagonists, or agonists. So it's a combination of two medication or two peptides. Zepbound or tirzepatide a bit more effective than Ozempic. These things have been extremely useful in weight loss in general, but it's interesting that they favor the loss of visceral adiposity. So if you look at a list of things that, and I get this question, well, what can I do to decrease my visceral adiposity? It just happens to be that GLP-1s are at the top of that list. Just the way that they change the physiology favors the loss of visceral adiposity. And that's why, like in the patient that I was talking about, he had lost a tremendous amount of weight and a tremendous amount of visceral adiposity, which normalized all his numbers. So I think a lot of the benefits that you see from GLP-1s that are coming out now, heart health, kidney health, are all, or the majority, I would say 80 and 90%, due to the effects of normalizing the metabolic function rather than a direct effect on the heart or a direct effect on the kidneys. So you're, again, going back to the environment, creating an environment that allows the body to function the way it should. We're getting rid of the impediments to normal physiologic function. Anything else about the GLP-1s? Okay, risks. Yeah, there are risks for any medication. I think there's been some actual change in the way that we're thinking about GLP-1s and muscle loss. So the initial scare was that you're going to lose a lot of muscle if you get on GLP-1s. And you can lose muscle, but you can also lose muscle if you lose weight in any other way. Most of the studies have been done with DEXA, and the DEXA can overestimate, because DEXA doesn't measure muscle mass, it measures lean mass. So lean mass includes blood volume and organ mass. So as we start to lose weight, especially if we're very overweight, we're going to lose blood mass, and we're also going to, our organs are actually going to get smaller. So some of that loss in lean mass is due to the shrinking of the organs and shrinking of the plasma volume. But it can still happen. But studies are pretty positive in that if you do resistance training, you can mitigate that loss. So you actually get less loss than you would just by taking it without doing any resistance training at all. I think I was going to mention one more thing.
If you, what about microdosing or tapering it
microdosing.
off, or?
So yeah, microdosing is interesting, and I'm very much in favor of it. And I think that we're going to start to notice that we're going to change the way that we're taking GLP-1s. Right now, or up until recently, it's been an injection you take every week. It increases your levels of GLP-1 that decrease during the week, and then you take the shot again and it increases, and then it decreases. Now with the advent of the GLP-1s in pill form, the increase in the GLP is happening on a daily basis, which mimics more what physiologically happens. So you have a peak during the day, and then it goes down at the end of the day. You take your pill again, it goes up and down. Now, what we could see is that different people need a different amount of GLP-1s in order to control their weight, and it could also be situational. So, for example, say that it's winter time, you know that you always gain 10 pounds a winter, you like to see the sun's not around, your appetite goes up. Maybe in those instances, you take a GLP-1 during the winter time, but during the summer, you're fine. So you're not on the GLP-1s all the time. It's situational. People that have lost a lot of weight, but then find themselves in social situations where they tend to overeat. Maybe they're going to a wedding or a birthday party, and they know they're just going to overdo it and destroy their diet. Maybe they can take a GLP-1 on that day, right, to mitigate their hunger and their cravings. And then more and more, we're starting to realize that GLP-1s can mitigate other cravings. Some people find that they don't drink as much alcohol, or they don't smoke as much as they did before. So I think we're going to find a lot of different uses and a lot of different dosing regimens for GLP-1s as time goes on.
I've seen a few reports about when people come off the GLP-1s now that they're actually having
weight gain. Yeah. So that's true. There was a recent study that was interesting, though, that a third of people maintained their weight. So two-thirds of people regained weight after being off of GLP-1s. A third stayed the same. And I think this is a reflection of a couple of things. And it may have nothing to do with GLP-1s specifically. It could have to do with genetics. It could have to do with our current food environment. So the question is, why do we gain weight? Why have we had this increase in obesity, and nobody really knows? Some studies suggest that it has to do with ultra-processed foods. There was this one study that they did. It was fairly complicated, but the gist was that the people that had ate ultra-processed food not only ate more calories, but it stimulated their hunger more for some reason. We don't know why. We're also finding out that there are people that are genetically predisposed to gaining weight. This has to do, there are really three what we call phenotypes of weight gain. So one is what we call the hungry brain. So these people don't release or don't have enough satiating hormones. So when we eat, our body releases hormones so that we feel satiated. Some of these people have a deficiency in that. so that they have to overeat in order to feel full. So each meal, they overeat, they have a huge meal. The other one is called the hungry gut, and this is similar in some ways where the gut doesn't release those satiating hormones, or the food passes through the gut a little bit more quickly. So these people have normal meals, they feel satiated, but then in 1 or 2 or 3 hours, they're hungry again. So these are the snackers, right? They're eating all during the day. And this is where intermittent fasting is useful. And then you have the emotional eaters. So they'll eat because they're stressed out, depression, anxiety. And the GLP-1s can help with all of these. And interestingly enough, even the emotional eaters get some benefit from the GLP-1s. So for some people, it has to do with lifestyle changes, and GLP-1s can help that. So you get people that maybe just have bad habits, and if they need a little help getting rid of that, as soon as they get rid of the bad habits, maybe that's the 1/3, right? That they get off of it, the GLP-1s has really helped them, and they're able to maintain that lifestyle. Then you have maybe the 2/3 that are genetically predisposed to gaining weight, and just like a diabetic, they have to be on that GLP-1 in some form for the rest of their lives. So it could be that it's intermittent. So maybe they have to take it once a week. Maybe they have to take it once every other week. Maybe they have to take a pill every day. Maybe they have to take it once every 3 days. So I think we're going to find more answers to that as time goes on.
One other question. So tying back to testosterone,
Mm-hmm.
there's a lot of different supplements that you can take. So are you seeing, I mean, it actually seems promising GLP-1s are now in pill form.
Yeah.
But testosterone seems like it wasn't very efficacious with pills, and like it's better. Like, what's the best? Is it pellet? Is it shots?
Is it for testosterone? Yeah. So like I mentioned before, we make testosterone is pulsatile. So we make testosterone at night, it peaks in the morning, and then it goes down during the day, and that's the natural form of things. What we're doing, what's very common now is taking injections, so that you have a huge, it's a depot injection, so you have a huge influx of testosterone, and then it goes down during the week. Some people take it twice, and then have 2 spikes. That's not ideal, because then you're getting exposed to a lot of testosterone all the time, day and night, and those people are at higher risk, for example, for increase in hematocrit, which is a thickening of the blood, and therefore increase in the risk of clots. Other forms give you more of a bump, like the gels that you can rub on yourself. Now they have a nasal spray that's even quicker onset and a higher bump, but it doesn't last as long. Not super popular because people don't want to give themselves a nasal spray like 2 or 3 times a day, but it can be useful in some circumstances where people just need a bump in testosterone in the morning. So there are different ways. The one that's under the skin, again, that's a slow release and it's more constant. So ideally, it's going to come out in pill form eventually. The problem is that you have to get past the digestive system, which can be challenging. And that may, just like the GLP-1s, may be more physiologically or mimic normal physiology.
I mean, in general, when people are trying to take the pill form, it's probably not going to be very.
If they take the pill form?
Obviously, like you said, 74% of studies are showing that they're actually supplement companies trying to improve.
Oh, yeah. Yeah.
They're not actually effective.
Yeah, so it depends on what they're selling. A lot of them just sell TRT in whatever form. You go to the clinic and then you can give a shot, or you can get a cream. The pills have never really been effective unless they've changed the formulation, because it has to go through the liver first, and that's where you run into liver issues. So if you can bypass the liver, and that's why you get it into the shot, sometimes you have that buccal in the mouth, because you're bypassing the digestive system, which is what you have to do with testosterone in the current formulations.
Dr. Winiarski, we got about 5 minutes till 8:30, and I know some people will need to scoot out. Do you want to touch on your thoughts about peptides in the
Yeah.
future?
So, peptides, it's just describing a class basically of medications. Peptides are a short chain of proteins. They're signaling proteins. GLP-1s are peptides. They've been changed. They've been modified. Typically, they don't last very long in the blood. So what they've done is they've added like a side chain or a side molecule to make it last longer. Some of these, and it's hard to talk about all peptides because they have different functions, but essentially they're signaling molecules and you're trying to trigger something. So, for example, there are signaling molecules like sermorelin, sermorelin, or tesamorelin that trigger the release of a growth hormone. Some are more effective than others. A lot of these have not been studied. In fact, most of them don't have a lot of studies in humans. Tesamorelin is different. It's been studied and it's FDA approved for HIV patients that need to drop a lot of visceral adiposity. But you have to decide whether or not those studies apply to you if you're interested in taking them. So I think they have a tremendous potential. We're still waiting on a lot of human studies to be done. Some people would say, well, they're never going to do those studies. And it could be true that they won't do those studies. The downside to that is that then we won't pick up long-term side effects. So we've done a lot of studies on GLP-1s, and we've noticed that, hey, you lose muscle, or the effects go away when you stop using it. That's the only reason we know that is because we've done studies on them, and a lot of studies on a lot of people. If you take something like MOTS, which is another one that's only been studied, I think, in mice, sure, these all sound great, and they work maybe great in mice, and theoretically they should work well in humans. But we don't have those long-term studies. So I'm not against peptides at all, but I think that we have to weigh the risks and the benefits. What do you want to get out of it? And similar to testosterone, are you using the peptides to mask some other dysfunction, some metabolic dysfunction, or are you using it to augment a very healthy system? I think most people are going to find that these peptides are most effective when they're paired with a healthy metabolism.
Mitchell, you have a question? No. Okay. All right, great. We're going to try to honor our time with these guys, but that was awesome. Dr. Winiarski, Van's going to wrap us up.
Okay.
But Dr. Winiarski, thank you so much for being here today, and he'll stick around for more questions if you have them after the presentation. Thank you.
Thanks.
Mm-hmm.